to Symposium 2 in Hall B, focusing on pulmonology with discussions on airway disorders, pulmonary sarcoidosis, and tuberculosis in immunocompromised patients. It is my pleasure to invite our chairpersons, Dr. S. Rishikesavan, President of the Sri Lanka College of Pulmonologists, and Dr. Chandimani Undugodage. I now warmly invite our chairpersons to introduce the speakers and panelists for this session.
Thank you. Good morning, ladies and gentlemen. Welcome to the Symposium on Pulmonology. We have three very interesting, timely topics today. We also have three esteemed speakers and four panelists gracing our sessions. So the first speaker is Prof Anoop Chauhan. Prof is no stranger to Sri Lanka and no stranger to this audience. He is a professor in respiratory medicine and consultant respiratory physician, Portsmouth Hospital's NHS Trust. Over to you, Prof.
Great. Thank you very much, Chandimani, and welcome to all of you to the Pulmonology Symposium. I'm very grateful for the invitation to talk to you today about eosinophilic airways disorder. Slight change to the program, but in keeping with the theme of the CCP sessions, the 58th sessions, we want to talk a little bit more about the future and future physicians and some of the tools and biologic treatments and other diagnostic strategies that are really important in this evolving area of disease. So I want to talk to you over the next 20 minutes or so about four key areas, really. Through four in-depth case presentations, I want to talk you through around the approach of eosinophilic airways disease and also go through a systematic approach about the definition and classification and causes of eosinophilia, and then particularly focusing on severe eosinophilic asthma and also how it may overlap with increasingly recognized EGPA, a much more fulminant multi-organ disease, and compare it with severe asthma, and also look at how we may be able to differentiate them clinically earlier, and then have a look at the role of biologic therapy in treating both diseases. So firstly, the definition of eosinophilia is any peripheral blood eosinophils of greater than 500 cells per microliter. But in reality, we see a lot of eosinophilic airways disease at levels lower than that, as one of the cases will illustrate. And in individuals with eosinophils greater than 1,500, it's termed hypereosinophilia. And there are three causes: primary, secondary, and idiopathic. We recognize primary as much more serious, usually accompanied by red flag symptoms, and it's usually driven by a malignant tumor, solid tumor, or a bone marrow disorder. But the more difficult thing is really to tease out the secondary causes of eosinophilia, and the most common ones are those as exemplified by this mnemonic. I find it difficult to remember all the different secondary causes of eosinophilia, but remembering this allows us to make sure that we evaluate this in our systematic approach. So thinking a little bit more about vasculitic connective tissue diseases, helminthic infection, clearly the most common cause of eosinophilia worldwide, and then more idiopathic hypereosinophilic syndromes, neoplasia, and then also allergic disease, which is the most common in developed countries as well. A detailed and systematic approach is really important in terms of assessing the causes of eosinophilia and the treatment options as well. It's like anything, as a physician, a really good detailed history, including travel and medication, are very important in this case. Again, screening for red flag symptoms will allow us to pick up potentially more serious causes, and then also urgent evaluation, usually in those with much, much higher levels of eosinophils as well. So good systemic screen of general, GI, respiratory, neurological, ENT, and also renal is important. But let's focus a little bit more on asthma and sinusitis and airways disease. So I want to illustrate that through the first case, Mrs. KP, who's a 45-year-old teacher whose main complaint was of an airways disorder. She couldn't stop coughing and wheezing, especially at night, which led to multiple exacerbations and at least 2 hospital admissions as well. So recurrent exacerbations, but that wasn't all in this case. She had chronic rhinosinusitis with nasal polyposis, and then a history of non-steroidal anti-inflammatory drug allergies or aspirin. But otherwise, in terms of social history, nothing there as a provocant, non-smoker, lived in the suburb, 2 children, and was adherent with medications as well. And the current medication was quite extensive, as you can see here, an inhaled corticosteroid, a long-acting bronchodilator, a leukotriene receptor antagonist. But she got to a stage where she couldn't get below 10 milligrams of prednisolone. So she'd become effectively steroid dependent. And on physical examination, she had the visible nasal polyps, but also the bilateral expiratory wheeze as well. And you can see the complementary blood results here. The thing that I'd like to point out is that she did have a mild eosinophilia, 450 cells per microliter, but clearly an airways disease that was uncontrolled. So in terms of pulmonary function tests, that confirmed the diagnosis of asthma, a reduced FEV1, an obstructed ratio, and also an 18% improvement after a bronchodilator. And her exhale nitric oxide, in keeping with the eosinophilic disease, was raised as well. There wasn't much on the imaging, including a chest X-ray and a chest CT, other than the CT sinuses confirming really quite bad pansinusitis. So in terms of questions, there are probably 5 things we need to learn a little more about from this case. Firstly, what are the additional investigations that you might perform? I think in most instances, stool for parasitic infection, sputum eosinophilia to confirm the degree of eosinophils, and also imaging if accessible. Does she fit the criteria of severe eosinophilic asthma? Yes, she's on high-dose inhaled therapy. She's on multiple controlled treatment. She's got a peripheral eosinophilia. She's had at least 2 exacerbations, 4 hospitalizations in her case, and then she's now become steroid dependent. Would she be a candidate for biologics? Yes, she meets all the criteria in terms of exacerbations, an eosinophilic or T2 signal, and also conventional therapy not helping. So in terms of choices, perhaps the first choice would probably be dupilumab. It's an anti-IL-4 and 13 biologic treatment delivered every 2 weeks, which targets both the asthma and the nasal polyposis. But there are other alternatives which I want to talk to you about briefly. We know that biologics can be expensive, and obviously in certain areas it's maybe inaccessible. But we realize that we now have about 6 different biologics at our disposal, but they all target airways disease in a different way, primarily in a T2 high eosinophilic disorder. Except omalizumab, it's indicated for individuals with high IgE, and in individuals without an obvious T2 signal. What I'd like to highlight is the use of tezepelumab, which is an anti-TSLP cytokine, and no specific T2 biomarker is required for that, while all the others require demonstration of blood eosinophilia and also high exhale nitric oxide, but also a clinical picture that is uncontrolled despite controlled therapy, so multiple exacerbations, recurrent oral corticosteroids. But the biologics experience has taught us there are particular clinical phenotypes that each biologic may be matched to, depending on the allergic nature, the number of exacerbations, the degree of eosinophilia, but also whether there is any non-eosinophilic or T2 low disease. So in terms of clinical decision matrix, these are the questions that we would ordinarily approach with patients with uncontrolled eosinophilic airways disease. Make an assessment of the allergies, the specific sensitizations, but also the number of exacerbations that they experience, as well as the degree of eosinophilia. In that last patient with a nasal polyposis, high eosinophils, we would probably have chosen dupilumab. But in individuals with much more eosinophilic and resistant disease, benralizumab and mepolizumab are good treatment options. So let's talk about case 2, JT. This is a 56-year-old female who was diagnosed with asthma in 2012, initially responded to treatment and kept really well for about 8 years. But in 2020, she deteriorated, requiring, again, maintenance oral corticosteroid, rather like the previous patient. She initiated on benralizumab. She had 5 oral steroids, fitted all the criteria, and then at the 12-month review, you can see the difference between the baseline and the 12 months, a reduction in the FeNO, a peripheral eosinophil depletion, an improvement in the ACQ score, so really good control of the asthma. Other comorbidities were important, including rhinosinusitis, sulfite sensitivity from the diet, and also previous sinus surgery. So like the previous case, one would probably assume this is just severe eosinophilic asthma that had responded well to benralizumab. But in 2022, patient presented with much more fulminant systemic conditions, so jaw claudication, peripheral neuropathy, and developed a positive ANCA, and a renal biopsy subsequently confirmed that there was at least a small to medium vasculitis treated on with high-dose anti-inflammatory treatment, as you can see, and diagnosed with EGPA. So this is EGPA becoming manifest on a patient with previous asthma and on a biologic treatment. Our current treatment, as you can see, is maintenance of oral steroids, benralizumab, along with azathioprine. So let's talk a little bit about EGPA itself. It's a very rare condition, but also difficult to diagnose. Traditionally, we recognize that there's an allergic component that often precedes the more severe eosinophilic and vasculitic condition. It can present with nasal symptoms, uncontrolled asthma, and then you get a phase where the patient becomes quite eosinophilic, and then the more severe manifestations as well. So we recognize that it's often a very difficult condition to diagnose because it overlaps with severe eosinophilic asthma. So in terms of trying to differentiate that, I've summarized this in this chart as well, but the factors we need to consider in all the cases that will help us differentiate is the presence of asthma and eosinophilia, which is a given, and then the peripheral blood cell count. It's often very high in EGPA, moderately so in severe eosinophilic asthma. And again, as you can see, ANCA can be positive, often negative, and then sinus CTs can also demonstrate chronic rhinosinusitis. But where tissue biopsy is available, you may see some mild inflammation or full-blown granulomatous vasculitis as well. The key here is that there are some patients who don't fit the criteria of EGPA completely, but also have an asthma plus syndrome. And this is what we would call HASM, or hypereosinophilic asthma with systemic manifestations. And now that's recognized as a more limited form of EGPA, where often there's involvement of asthma, airways disease, sinuses, but also cardiac in these individuals as well. And that's without multi-organ damage. So again, there are different treatment options and approach for this case. So in terms of EGPA, we recognize that the classification has changed over the years. Going back as far back as the late 80s and early 90s, the American College of Rheumatology classified 7 criteria, as you can see in the left-hand column, and then subsequently other multiple guidelines and esteemed bodies have tried to diagnose, classify and define EGPA, and those are summarized. But essentially, they all have asthma, eosinophilia, and a degree of neuropathy, pulmonary infiltrates, and also paranasal sinus abnormalities. But in terms of defining treatment options and choosing patients for a clinical trial, there are 2 studies, the MIRA and Mandara studies that have been published in the last few years. Their definition was a little more liberal: asthma, eosinophilia, and the presence of pulmonary infiltrates, and then any 2 of the other criteria. And these patients were then entered into multi-center global studies, and the outcome of that, which I'd like to summarize. So recognizing that in EGPA, you get 3 components. You get an allergic component, an eosinophilic, and a vasculitic, as we have traditionally understood. Certainly, our standard treatment, oral corticosteroids, will treat both the eosinophilic and the vasculitic pathways, whereas biologics will treat the eosinophilic pathways, and vasculitis really depends on quite good immunosuppression. So comparing the 2 trials, both published in the New England Journal, phase 3 high-quality randomized controlled trial. The first one was mepolizumab, 300 milligrams delivered every month in a population of 136 patients with EGPA. What you can see here is that there was the age range was similar for both trials. The Mandara trial didn't compare placebo, but it was a head-to-head comparison between benralizumab and mepolizumab. As you can see, the dosing was slightly different than we have in the asthma, much higher doses and slightly more frequent in the benralizumab group. The key findings were that there was a reduction in the number of relapses patients experienced at the end of one year or so. But also, the number of patients who are able to be weaned off oral corticosteroids, which I'll demonstrate in the table. So the chart on the left shows the relapse rate between placebo and mepolizumab, which you can see a significant reduction. But note that even patients on mepolizumab didn't see an obliteration of relapses. They still experienced them. And similarly, between benralizumab and mepolizumab, there was a similar comparison in both groups. So what can we conclude from this is that both mepolizumab and benralizumab are equally efficacious in EGPA. They both allow a reduction in oral corticosteroids, and as you can see between benralizumab and mepolizumab, 41% were able to withdraw completely in benralizumab, 27% in mepolizumab, and then also the quantity of steroid reduction is evident. The important thing about this trial and the international nature of the study is that it allows healthcare regulatory bodies to look at the health economic impact of this. And only a month ago, the National Institute of Health and Care Excellence in the UK now recommends the use of benralizumab as an add-on treatment for patients with EGPA with chronic relapsing disease. So I want to illustrate this with another case, JM, a patient who was on the Bandara trial, who was diagnosed with asthma at the age of 19 years, but in 2017 developed EGPA, and you can see the full house of symptoms there. Positive anchor, CT chest showing some ground glass opacification, a positive sinus CT, and a rectal biopsy confirming granulomatous formation as well. But what's interesting here is that this patient was stabilized with EGPA, enrolled into the Bandara study. In hindsight, they'd received benralizumab, but also through a sequence over the next few years, the patient was tapered off prednisolone and methotrexate because of some side effects as well. And in February 23, had weaned off completely of all those treatments. And in June, the patient suffered an EGPA flare, and mycophenolate was used to try and treat the patient again as well. So this demonstrates even with controlling the eosinophilic component, you're still at risk of vasculitic disease. So in terms of approaching the vasculitic component, we have several options as well. But generally, the guidelines coalesce to the use of methotrexate, prednisolone, tapering, but also the use of cyclophosphamide and also rituximab in those patients with very, very severe disease. But the important thing here is that combination of anti-IL-5 treatment can be used as an adjunct to all of these as well. So another case, this is the patient who chronic rhinosinusitis developed before anything requiring surgery, and then about 8 years later, then developing the obvious asthma symptoms, again with the eosinophilic esophagitis 2 years later, initiated on benralizumab with excellent control of the asthma, a reduction in exacerbations, and you can see the reduction in blood eosinophil counts and the asthma control questionnaire, and also the anchor became negative. Comorbidities were treated. However, in 2022, despite treatment and despite really good asthma control, the patient developed with increasing sinonasal disease, with a large septal perforation, and then developed a PR3 positive C-anchor with inflammatory disease and then flare-up of the EGPA, as you can see. Again, an illustration of a patient with benralizumab, but still at risk of developing disease. So what does this mean? I think it tells us that there are related but slightly separate pathways in eosinophilic Airways disease, especially in EGPA as well. So the drug in terms of de-escalation is really important in terms of understanding the different components. The cases that I've demonstrated have illustrated that even with anti-IL-5 treatment, you can taper patients off steroids, get excellent asthma control, but sometimes you do not reduce the risk of vasculitic disease as well. So it really requires vigilance throughout this period as well. In terms of de-escalation, there are multiple factors that will determine what you de-escalate from in this severe disease. It'll depend on the number of organs involved, the biomarker response, systemic involvement, and also drug side effects, and also the specialist team available. I think from our experience, individuals with severe eosinophilic asthma can safely be tapered of all steroids. They don't require immunosuppressants, and anti-IL-5 medication can certainly help. In individuals with EGPA, it's really important that IL-5 treatment can help, but also thinking a little bit more about the risk of vasculitis and monitoring the biomarker responses, and the peripheral biomarkers of systemic response are really important as well. So in those individuals, it'll be probably an anti-IL-5 or at least one of steroids or immunosuppressants as well. There are no good biomarkers of vasculitis other than CRP and ESR, but certainly in EGPA. But amyloidosis A1 and fibrinogen and other biomarkers are now being tested with some good potential results. So, in terms of learning points from all of this, we recognize that eosinophilic airways disease is complex, especially with the use of biologics. It improves asthma control, but it sometimes doesn't always reduce the risk of more severe fulminant vasculitic disease. So EGPA and severe eosinophilic asthma may involve multiple organ systems. They require a comprehensive and a multidisciplinary approach. We certainly can use the biomarkers available at our disposal, blood eosinophils, FeNO, to help us guide in terms of treatment plan as well. Also, the biologic therapies also have a significant role, not only in severe eosinophilic asthma, but especially in individuals with much more severe vasculitic multi-organ disease. So the chronic and relapsing nature of vasculitis, both conditions, including severe asthma, they're chronic, they're prone to relapses, and they require long-term strategies and adjustments in therapy based on disease activity and also patient response as well. The important thing is that in the absence of having access to biologics, there are some key things about severe asthma, that comorbidities are really important. And it's important that we maintain vigilance of all of these, treating the obesity, the dietary, lifestyle, lack of exercise, smoking, vaping, and also the other uncontrolled issues such as poor adherence in some of these patients as well. So we can't forget that. So in summary, the eosinophilic airways disorder spectrum is evolving rapidly. The use of biologics are important, but hopefully these cases have demonstrated that when you approach patients with severe eosinophilic disease, you need to remain vigilant throughout for the risk of vasculitis. And at the moment, we don't have any biomarkers, but there is some hope in the future that we may have some. Thank you.
Thank you, Prof. Anoop Chauhan, for the excellent talk. We will have the questions and the discussion after end of all the topics. So the second line of topic is managing pulmonary sarcoidosis. It's done by Prof Ling Pei Ho. She's a professor of respiratory immunology at Weatherhill Institute of Molecular Medicine, University of Oxford, and consultant respiratory physician at Oxford University Hospital. Over to you. Thank you.
So, good morning, everybody. Let me just adjust things. So, thanks. It's a wonderful pleasure to be here, and I thank the organizers very much for having me here. Today I'm going to talk about an approach to diagnosis and management of pulmonary sarcoidosis with a focus on pulmonary disease. But of course, as you know, sarcoidosis is a multi-system disease, and I hope this will be helpful to all of you. I know sarcoidosis is not a very common disease in Sri Lanka, and that's actually what I thought in the UK 20 to 25 years ago when I started looking after patients with sarcoidosis. But in fact, if you know about the disease and you understand it, it may well be that you find that it's more than you think. So I'm going back to basics here. Again, this is very much with trying to help all of us understand the condition and how to manage it and what it is before thinking about the future as such. So sarcoidosis is an enigmatic disease. It can be hard to manage. And in this talk, I would like to try and explain why sarcoidosis is hard to manage, how we deal with this difficulty, which treatment we use when, and hopefully leave you with a practical approach for managing sarcoidosis. I'm not going to address very much about the pathogenesis of sarcoidosis in depth. I've got here two reviews that are very good from people I know, which I invite you to look at your leisure. So what is sarcoidosis? When my patient asks me what sarcoidosis is, I tend to say it's an immunological disorder. is characterized by hyperactive lymphocytes, particularly the CD4 T cell component, and it forms granuloma, which is an entity comprising activated macrophages coalescing around a center and surrounded by these CD4 lymphocytes. Of course, I don't tell them all of that, but I say it's an immunological disorder, and it's caused by a complex interaction between genetic predisposition, host factors like stress or infections and environmental antigens can trigger sarcoidosis. So, for example, you will see that after the Twin Tower disaster in New York some decades ago, many of the firemen came back and were diagnosed with sarcoidosis. So there's often an environmental trigger, but there needs to be a marriage between the genetic predisposition and some host factors. So this is this granuloma is the underlying factor in all the disease that you'll see. But overlaying this granuloma, which is common to every disease, are very many different types of sarcoidosis. You get people who presents with erythema nodosum. You see some of this in TB as well. And with CT scans like this, chest x-ray like this, but also lupus pernio, like so, joint disease, alopecia, uveitis, and conjunctivitis, heart disease, liver disease, and diseases like this where the CT scan is full of scars and many other types of conditions. So there are many phases to sarcoidosis. And not only that, sarcoidosis is a great mimic and can be a companion to many other diseases. So is this CT scan here showing TB or sarcoidosis? In fact, this is one of my patients, and he has got sarcoidosis, but he could well have tuberculosis. And is this lymphoma or sarcoidosis? Again, another patient of ours who actually turned out to have lymphoma. And I'm now going to run through 4 cases quite quickly to illustrate some of the difficulties that we face with when managing sarcoidosis. And then I'll come to how we manage these difficulties. So the first case is that of a 37-year-old happy chappy Afro-Caribbean construction worker who was never a smoker, has a tissue support for his diagnosis, and was diagnosed some years ago just with cough, no breathlessness. He had a high serum ACE level and lung function that was abnormal. So the TLCO is 54% of predicted. And this is his CT scan, full of masses, large volume disease throughout the lungs, nodularity, and we were quite alarmed by this patient. But he said, sorry, no steroids for me. I really want to be fit and well, and he declined treatment. So we had no choice but to follow him up and monitor him. And we did so for 7 years, and this is the CT scan 7 years later. Pretty good, with some healing by scarring and nothing else. So no treatment, and this case illustrates that some disease can actually regress without treatment. The second case is that of a 65-year-old company director, a never smoker again, tissue support is in place, diagnosed some years ago, again with cough and no other symptoms. And this is his chest CT at presentation. Let's see if I can get some. So masses, masses, and then very little else apart from the mass I showed you. But a few years later, he presented again with breathlessness, lung function deteriorated, and steroids were started. But despite steroids, he went on to have progressive disease. He had a PE and then another one, and developed CTAF, liver disease, and he was finally referred to me in Oxford. And we started to add in mycophenolate and methotrexate, and we were able to control his condition. But in fact, this went on to progress for quite a bit until he had this end stage lung and respiratory failure. So some disease like his started mild with just a small amount of disease in the beginning, but can become unresponsive to treatment. The third case is that of a 45-year-old teacher. Again, tissue confirmed sarcoidosis, no infectious agents in the bowel, bronchoalveolar lavage, and again, cough. But she had a bit of breathlessness, and the lung function was clearly reduced, ACE high, suggesting active disease, and this was her presenting CT. Masses bilaterally, lymph nodes, and a lot of nodularity, and she was started on prednisolone. And she responded really well to prednisolone, and by 2015, we were able to tail her off the steroids, and she did very well, and she's now discharged from follow-up. So some patients like her show excellent response to prednisolone. And finally, that of a 58-year-old mathematician who came with no symptoms. He just had a breast lump. We biopsied the breast lump, which showed granuloma, and had a little bit of high serum ACE, the upper limit in UK being 55, and a normal lung function. He cycles to his mathematics institute 8 miles per day, and he said, well, what do I do here? And this is lung CT scan. So this is a typical CT scan with nodularity throughout the lungs, a star filling the night sky picture that we see sometimes. And it was found from apex to basis. And because he was well, we didn't start him on treatment, but monitored him. And again, his disease resolved without treatment. So there are some disease that resolve without treatment despite high volume, worrying looking disease. So this is one of the key issues in management of sarcoidosis. It is a very heterogeneous disease. There's heterogeneity in the subtype of the kind of pulmonary disease we see. You can have patients presenting at different stages of disease, and there are some patients who present almost with no symptoms, and some patients with a lot of symptoms, and some patients who respond to disease treatment, and some that don't, and some patients who present with different dominant organs other than the lungs, although the lungs are affected in 90% of the time. So how do we resolve this, and how do we manage this heterogeneity and difficulty in deciding who needs treatment and who will benefit most from this treatment? And here I propose 6 key questions that you ask when you see, say, somebody with pulmonary disease especially. So these 6 questions are, firstly, we need to ensure that the diagnosis is secure. And then what subtype of pulmonary disease it is. As you can see from the cases, they don't all present with the same type of lung disease. And then importantly, is there active fibrosis? Not just fibrosis, but is the fibrosis active? And then is there an organ dysfunction or a threat to the organ? Is there high volume lung disease? And finally, are there special organs involved like the heart, the eyes, and the brain? And with these 6 questions, you then decide whether you treat or monitor the patients. So let me go through this one by one. And the first is to think about the diagnosis. So you see from the cases I presented that the CT scan is pretty central to making a diagnosis, but also a multidisciplinary team approach. And I want to go through the CT radiology patterns quickly. The thoracic high-resolution CT scan really, at least for us, is the most key tool in our diagnosis. It is, of course, much more sensitive than chest X-ray. And the two things you will see is lymphadenopathy and characteristic lung parenchymal changes comprising nodules, ground glass changes, consolidation, and interlobular septal thickening. And in about 20% of the case, also fibrosis. So let me focus on two of these features. In terms of lymphadenopathy, the typical kind of lymphadenopathy you'll find on CT scan is that which is bilateral and symmetrical. If they're not bilateral and symmetrical, we need to think of something else like cancer or tuberculosis. They're usually well demarcated and is 99% of the time in the hilar and 30% of the time also involving the mediastinum, and it often is calcified, either amorphously, like here, or more discretely. As I said, the atypical ones tend to be unilateral, and they can also be necrosis. And of course, particularly in Sri Lanka and India, the key thing you need to think about then is tuberculosis. The nodules are typically micronodular or macronodular, as defined here by the measurements of 2 to 4 millimeters or more than 5 millimeters. And typically, they are perilymphatic in distribution, peribronchovascular, subpleural, interlobular, or in the interlobular septa, and they have an upper and middle zone predominance. And they can be atypical nodularity, and this is where really in this part of the world, things become a lot more difficult. So in terms of macronodules, this is what you will see, this fissural nodularity, and small, less than 4 millimeter nodules, usually scattered along the bronchovascular distribution. And the macronodules in such, as you can see here and here, often the macronodules are not as numerous as the micronodules. And there is this typical galaxy sign that you hear your radiologist talk to you about. This is typically a conglomeration of small micronodules around sometimes what the radiologists will tell you is a galaxy like so, and scattered and in clusters throughout the lungs. So these are quite typical changes on CT scan. And 90% of the time, we can make a diagnosis of sarcoidosis now on high-resolution CT scan alone, and particularly if you have a thoracic radiologist with interest in sarcoidosis. So much so that the British Thoracic Society has actually said that we can, in the right setting, with the right multidisciplinary teams in place, you can make a diagnosis of sarcoidosis without tissue confirmation. But I think in Sri Lanka, it may be a slightly different picture because TB, of course, is the first thing you need to think about when you see these kind of things. And then there's this question of cavitation. And this is quite a vexed problem. This CT scan here is actually a scan of a patient of mine with clear cavities here. And of course, the main differential diagnosis is really TB, fungal, or non-tuberculous mycobacteria or sarcoidosis. But in this case, we have a presence of both sarcoidosis and TB in this patient growing tuberculous particles about 6 to 7 years after the diagnosis of sarcoidosis. So a key problem, the key point here really is to remember that it's not either TB or sarcoidosis. Not uncommonly, they can coexist. So let's go back to the diagnosis and securing this. So we've gone through the typical radiology pattern and then ensuring that there's no alternative disease and considering coexisting diseases, as I've talked about. And then often for all patients, biochemical and hematological analysis to screen for other organ involvement and bronchoscopy if required. Most commonly these days, we would go for an EBUS TBNA rather than a transbronchial biopsy. But the lavage is often important to exclude tuberculosis or fungal involvement. The role of PET scan is a little bit less useful for us. Is really to look at extrapulmonary involvement if indicated, and often to look at disease activity in consolidation or masses in the lungs when we ask ourselves whether the consolidation is due to active disease or fibrosis. Now let's go to the second question, which is what subtype of pulmonary disease? And the reason this is important is because we know that when the patient presents with pulmonary sarcoidosis, you can actually usually divide them into 5 categories. That with no lung parenchymal disease, like so, just lymphadenopathy, normal lung parenchyma. That with what we call simple active disease, nodularity, ground glass consolidation, or interlobular septal thickening. And then there's this curious type, which is a distinct classification, where there's simple but active disease and perihilar conglomeration. So this presence of masses in the hilum or in continuation with the hilum and nodularity around it. And then there is the fibrosis, which is active, which I'll come to in a minute, or inactive, and those with complications. And the reason that's important for us to look at the CT scan in this way is because we know that from a recent study from our group, that those patients with this picture, the conglomeration picture, is the kind of patients who are most likely to progress to fibrosis. And so we pay particular attention to those with perihilar conglomeration and consolidation, and think about treatment for this more carefully than for the other diseases, despite difference in volume of disease. And then there's this question of whether your fibrosis is active or inactive. So the kind of older sarcoidosis physicians will talk to you about burnt out disease. And we like to call it inactive disease more than not, but mainly because there is an active component of the inactive fibrosis. And this active fibrosis is really the most, the disease that's most feared by a lot of sarcoidosis physicians, because this is a disease which is very likely to progress with difficulty in management. So when you see fibrosis, which is reticulation and architectural distortion of CT scan, with any of these features, nodularity, ground glass changes, interlobular septal thickening, or consolidation, then this is what we call active fibrosis. Without any of this, then this is inactive fibrosis. And the active fibrosis is the one that we look for most in patients with pulmonary disease, and they will trump everything else in terms of requirement or not for treatment. End organ dysfunction is important because we know that even with very large volume disease, if there's no threat to the organ, then the treatment can actually be worse than the disease itself. So look for lung function, particularly the forced vital capacity at FEV1 and TLCO are the three we look for when we look at our patients. The fifth question is high volume disease. So what do I mean by this? There's no clear kind of cutoff as to what is high and what is low, but we tend to be able to look at the volume of disease on a CT scan being a 3D construction and say, at least in Oxford, that the low are the ones with mild disease, 0 to 25% of the volume affected, and the high are those with disease more than 50% of the volume affected. And the patients with a high volume disease, despite not having fibrosis, is a disease that we tend to want to treat because the threat to the organ is greater. And finally, which are the special organs that always require treatment? And these are patients with cardiac sarcoidosis, those with progressive neurological sarcoidosis, hypercalcemia, some of you will see this in your acute medicine, renal sarcoidosis, and eye sarcoidosis. So whatever the lung shows, even if there's no lung parenchymal changes, these patients will always require drug treatment. And then when you decide to treat, then the people in summary who needs treatment are those with active fibrosis, those with pulmonary disease with end organ dysfunction, that is abnormal lung function, those with a threat to their organs and a threat to progression to fibrosis, which this is those with large volume disease and those with perihilar conglomeration. And those who require really close monitoring are those with high volume disease but no end organ dysfunction. So those with normal lung function, a very large amount of nodularity, and those with perihilar conglomeration and normal lung function. The corollary to this is that it does mean that those with active disease doesn't always need treatment. So those with high serum A's, those with high nodularity, like our mathematicians, don't always need treatment. And those with abnormal lung function but inactive fibrosis also don't usually need treatment. So there's a bit of nuance to management of this disease, but we'll go through again in the last slide the kind of 6 questions we ask. And over the years, we know that if we get these basics right, the patients will not be under or over treated. And then in the next few slides, how to treat sarcoidosis. Once you have got the diagnosis secure, once you've decided, yes, this is the patient I need to treat with drugs, then prednisolone is always the first choice. And there's a good reason for this. We know that the disease mechanism in sarcoidosis is complex, so there's likely to be more than 4 or 5 pathways that contribute to the formation of granuloma. And prednisolone is the one that would guarantee the hit of hitting all these pathways. Not only that, there is a strategy called the control and maintain strategy, which is that you first achieve control of the disease activity by giving slightly more prednisolone, usually at 30 milligrams per day, and that's sufficient. And then tail it off and keep it and maintain this control for 6 months, at least, but up to 24 months, at a very small level, so 5 milligrams per day. So achieve control and then maintain the control, and this is a control and maintain strategy. And in terms of the latest nintedanib and infliximab drugs that's come onto the scene of treatment, the key thing to remember for nintedanib is that primarily sarcoidosis is an inflammatory disease. So primarily it's not a fibrotic disease, unlike idiopathic pulmonary fibrosis. So primarily we need to treat the inflammation and treat it with steroids or immunosuppressants. And when there's evidence that the fibrosis has progressed despite us not being able to contain the inflammation, that's when we use nintedanib. And infliximab adds to the immunosuppressant or the anti-inflammatory component of the contain and maintain strategy. So this is my last slide. So what are the take-home messages? So sarcoidosis is complex, but over the years, we've come to know that getting the basics right is important. In terms of whether the patient needs treatment or not, it's important to remember that the treatment can sometimes be more toxic than the disease itself. We always ask the 6 key questions, and always remember that not all patients require treatment. But if you do find a patient with active fibrosis, then it trumps all other considerations for treatment. Prednisolone is still the first choice. You don't need a high amount of steroids to control the disease, but you do need to be able to control the disease within the first 2 to 3 months, and then to maintain this control for about 6 months with a low dose steroids. And the requirement for this 6 months of treatment is because granuloma itself is a immunological entity that requires a persistent hit for over a long period of time to keep it under control. And I will just leave you with this British Thoracic Society clinical statements on pulmonary sarcoidosis, which really says that although it's challenging, the kind of landscape of management of disease is now going through to looking at the patient as an individual. Of course, we should always do that anyway, but particularly in sarcoidosis because of the heterogeneity of the disease. And I think in Sri Lanka, probably the main thing is really to try and ensure the diagnosis is secure in the first place. And then just looking for the disease and thinking about it. And hopefully the next time I see you, perhaps in 10 years' time, we will have a situation where you can tell whether there's sarcoidosis or not, and how much there is in Sri Lanka, and how you differentiate that from tuberculosis, which will be the greatest threat to sarcoidosis diagnosis in this region. So thank you very much for your attention, and I'll take any questions.
Thank you very much, Professor, for that excellent talk. We move on to the third talk of the symposium. And may I kindly invite Dr. Eshanth Perera. Dr. Eshanth Perera is a senior consultant respiratory physician attached to the National Hospital of Respiratory Diseases at Welisara. He's going to talk to us on optimizing latent TB management in the immunocompromised. Over to you, sir.
Thank you, Chairpersons and the Council of the Lanka College of Physicians. giving me this opportunity to talk on latent TB infections, which is very relevant for this region. So when you consider the latent TB in the immunocompromised populations, we need to consider about the global burden of TB. We need to remember that 1/4 of the world is having latent TB infection, and there's a significant activity TB disease burden as well. And still TB remains one of the leading cause of infectious disease deaths in the world. So coming back to latent TB infections, what is it? It's a state of persistent immune response to stimulation by mycobacterial antigens, tuberculous antigens, with no evidence of clinically manifesting active disease. So in this state, you may call it that MTB is there, but not having active disease, but you may call it as the bacteria gone into a sleep. So bacilli are there, but they're clinically, radiologically, and microbiologically, it doesn't manifest. You cannot prove. So therefore, not much of a worry about spreading the disease to the others. But in this immunocompromised population, they are most at risk because it's unlike in the other rest of the population who are not having immunocompromised states. It's not just dormant. It may at any moment get reactivated, and it's going to be a ticking threat. So in 2018, the WHO, in their strategy of ending TB by 2035, they decided to target this group of latent TB infections in the immunocompromised source as well. So they advised the nations to develop their own guidelines to treat these latent TB infections. So we went ahead as well, and as a college and the national program, and developed the guidelines for latent TB infection management. Why does it matter? There is increased risk of progression and developing into active disease, as I said earlier, and the severity and mortality in this group of patients is going to be higher because of the control mechanism is not going to be there, and obviously it will result in more active disease and spreading into the rest of the world, the population. So in the context of controlling TB and in the programmatic management also, this group becomes more important. And also not like the earlier days when we were registrars and senior registrars. Those days we just offered latent TB infection management to children under 5 years of age. Now these days, with the advent of more and more immunomodulator therapies, cancer treatments, and so on, and various risk factors and various risk groups, the treatment and making it incorporating into guidelines of patient management has become important. So you need to have a practical risk stratification framework, and you need to decide who to screen, how often to screen, and with what we are going to screen. So these are the groups of people who are at risk, the people living with HIV, and those who are on immunomodulator therapies like TNF-alpha inhibitor therapies and JAK inhibitors, and corticosteroids, of course, and the oncological treatments. And even in our country, we have started lots of transplants of various solid and hematopoietic stem cell transplants. And certain cancers are at higher risk of developing immunosuppression. And of course, we are in the continent for having a high disease burden of diabetes, chronic renal failure, and also silicosis patients who are at risk of developing TB when they have latent TB infections. Of course, we had good old days, we have been having these children under 5 years of age as well. So coming back to our basics on active TB diagnosis, that's very important. When you cannot talk about latent TB infections without ruling out active TB infection disease. So you have the obvious clinical features. WHO gives the 4 symptom screen, like the chronic cough for more than 2 weeks, the loss of weights and low-grade fever and the night sweats. Radiologically, it's important the chest X-rays and other radiological investigations to confirm it. But in this particular immunosuppressed patients, you need to remember they may appear normal or can show atypical patterns, and it may be missed by even the experienced hands. And microbiology also, maybe there will be flaws when you are going to detect them active TB in the immunocompromised group. So therefore, in this immunocompromised population, a single test may not be enough. You need an layered assessment for the detection of TB in these patients. You need to consider the risk groups, the exposure risks, the imagings and biomarkers, and serial testings. Obviously, we may have one test may not be enough, or may have to do a serial testings. So good old days, our usual normal things we don't forget. There's microbiology in smear microscopy, which is low cost and a rapid method, but it has its own deficiencies like the low sensitivity, especially in this group of people who are paucibacillary, because non-cavitary diseases, and immunosuppressed may not be, when you try to do the sampling, it may not be detected. And also, even if it is positive, you may not be able to detect the Mycobacteria tuberculosis and non-tubercular mycobacteria, which are more common also in this group of patients. So you may not be able to differentiate between the MPTBs and the NTMs. Cultures, of course, is the gold standard in diagnosing of TB with a high sensitivity, but you have other problems as well, because it has some drawbacks like long turnaround time, and this delay, you cannot wait for the culture to be positive in an immunocompromised patient. And also, you need some resources for do these cultures, and also here again, the cultures may become negative in these immunocompromised patients because of the less cavitations. Also, there may be more EPTB patients, and which are more difficult to get the microbiological cultures, samples for culture. We always have this next things which have been there for more than about 12 years in Sri Lanka, the nucleic acid amplification test like Expert and Expert Ultras. There again, sometimes in this population of patients, because of the smear negativity and paucibacillus states and the EPTB states, the detection may not be that easy. And one important aspect of these patients in these tests will be they cannot distinguish the DNA of a non-viable or a dead bacilli from a viable bacteria, and therefore it can give rise to false positive results. Where there is no active disease, you may get a NAT positivity. So there are other new ancillary tools as well, as in immunocompromised patients you are going to use for like TB-LAM, which is a urine-based lipoarabinomannan antigen detection, especially in HIV patients with very low CD4 counts, and there are other advanced amplification tests as well. Coming to my topic of latent TB infections, how you are going to diagnose. As I said earlier, clinically they don't have symptoms, and radiologically may not be possible to find anything. They don't manifest like, and microbiologically nil of no tribe. So you are going to diagnose them with the latent TB investigations, which are immune-based, like TST or tubercular sensitivity test, the skin, the Mantoux test, and also the IGRAS, the interferon gamma releasing assays. The main types are the quantiferon gold and the T-spot test. We have the first one. But again, there are other some specific limitations in the LTBI population in the immunocompromised states. There is reduced sensitivity of both these tests because these are host-based diagnostic tests, and an immune response is crucial for the function. Obviously, the immunocompromised patients will not mount that kind of a response. So, in this interpretation of this LTBI test, sensitivities, you need to remember, they don't have the overlapping sensitivities. That means TST become positive, it's not going to be always IGRA positive as well, and the vice versa. And also the positivity of either of TST or IGRA is considered therefore a positive case. So therefore, we suggest that testing both TSTs and IGRA simultaneously to minimize the false negative results. But the problem is we can offer only the TST widely in the state sector. In other forms in the government sector, we are planning to introduce into the National TB Reference Laboratory, but it's not been widely available in the state sector. Therefore, the patients have to spend something like 30 to 40,000 rupees per test. So we need to have a method of doing one, and if it is negative, to go in for the other IGRAs. But the problem is the purified protein derivative which you use for the TSTs itself will be a stimulus for IGRAs. So it can mount a false positive reaction. So therefore, it's been suggested that the immune response comes after about 10 days later. So within 7 days of the TSTs to perform the IGRA test, it has been suggested. So since for practical reasons, patients are coming from the transplant centers and other specialties after a TST test after about a couple of weeks, so we suggest that TST be performed on day 1, and if possible to do both at the same time. Otherwise, on the day of reading of the TST, on day 3, to get the blood sample so that the patient is there for you to test it. When you interpret the TSTs in immunocompromised populations, it's important to note that the cutoff points are less depending on the immunity. You go for 10 millimeter for MAN2 on a normal individual, but in the immunocompromised patients, you go for 5 millimeters or above depending on the immunological state of the patient. But even with these adjustments, can miss a significant number of TB cases in these patients, all TBI cases, because of the for example, in chronic renal disease, the cutaneous energy itself may be a problem of mounting a proper TST response. IGRAs also having the similar kind of problems because of the intermittent, you can have indeterminate results because of the low immune response. So, and also there's a problem of inability to differentiate between the latent TB and active TB disease in the IGRAs as a general limitation in these patients. So, when you are diagnosing latent TB infections, you have to actively exclude TB, clinically, radiologically, and microbiologically. And if either TST or IGRAs are positive for the first time, and if not adequately being treated for latent TB or active disease, you consider it as a current latent TB infection. Let me give some scenarios which you need to consider. And now, a patient may come with a prior documented history of positive TST or IGRA to you in transplant setting or the immunocompromised setting. You need to see what you are going to do. First, exclude active TB, but you don't go for retesting. Even if they have a prior report of positivity, you don't go for TBI testing again because it's the lasting immune sensitivity is there. But there are other patients like asymptomatic patients with chest X-ray evidence of past TB, but will not give a history of adequate treatment. There again, you need to exclude active disease. In these patients, once you have excluded active disease, you consider it as a latent TB infection, irrespective of their TST or IGRA results. In other instances where they have been adequately treated for LTBI or active disease, still again you go for exclusion of the active disease, and again you don't go for retesting for LTBI infection. Those who are having active TB, suspected individuals, you will need more advanced diagnostic tests to exclude disease, active disease, including other clinical specimens for microbiology or histology, like induced sputum, BAL, CSF, serosulfate, depending on the situation, and also other radiology like HRCT. So we do not go for all patients who subject HRCT and all unless we need to consider the scenarios. So in all these clinical scenarios, it's very important, even after diagnosis, important to consider this locality and the risk of exposures, their travels, where they live, depending on where we have certain districts of the country which are having higher TB burden and settings as well. And also they need to be followed up for, it's very important, even after a transplant, even the post-transplant setting also will be followed up. Coming to treatment strategies, you need to consider, there are certain things you consider in selecting your treatment regimens, like the patient factors. We have different regimens of 4, 6H, like 6 months of INH therapy or kind of things. Those who are having past, or people living with HIV with a chest X-ray showing previous disease, you may not select INH as the treatment because of the possibilities of resistance to that as well. And also you need to consider the treatment adherence and for their effectiveness, because these patients are not having obvious disease. They are not interested in completing the treatment, especially if you are going to go for intermittent treatment regimens in the LTBI treatment. You have to have directly observed treatments for these patients. And you need to be mindful about the drug-to-drug interactions of these patients with the other disease you are treating with. So interactions are very complex and depend on specific type drugs you are using, and you need to get the opinion of the experts. For example, the chemotherapeutic effectiveness may be reduced in like the agents like cytochrome, those who are subsets for the cytochrome P450 systems, and making them susceptible to the drug interactions of the rifamycin, which induce them, the liver enzyme, and the calcineurin inhibitors like cyclosporine and the ARVs may not be that effective if you are going to select a regimen with rifamycins. And there are other toxicities which may be complex, like when you are using certain anti-TB drugs, and the hepatotoxicity of the INH and other drugs you are using for the other diseases may be important as well. So you need to remember LTBI subgroup is they are not having clinical features. So you need to go for a shorter course of regimens for obviously for the compliance, and this is better for the safety profiles, and also completion rates are higher. We have a different depending on the availability of drugs, but there are other regimens WHO has suggested. The 4 months of daily rifamycins, rifampicin, or 3HR, the 3 months daily INH and rifampicin, or 3HP. This has been available again to the last one also available in our country. Once weekly, or 12 doses of INH and rifampicin once a week. So this is an intermittent kind of treatment regimens. So people may forget to take this in. So in this group of patients, remember to have kind of a directly observed treatment course for these patients. Otherwise, you give 12 tablets straight away and they may not take it. There are alternative regimens, although we are using it in Sri Lanka, and or 6H, 6 monthly daily INH. It is an older regimen we have been using with higher risk of toxicity and lower completion rates as well. And at times they have suggested 9NH or 9 months of INH also, further higher toxicity. So in this patient group, you need to have a stepwise decision-making model. You have to screen them, stratify them accordingly to their the other disease and the immunological states. You need to tailor therapy according to their other medications and their immunosuppression states, and the monitoring is very important. So LTBI management implications in this population, this is very important to note that preventive therapy of LTBI is the critical component of this medical care. So pre-treatment screening should always be carried out before starting immunosuppressive therapy or undergoing organ transplantation. Even in the chronic renal failure patients who are waiting for KT, we suggest that before starting the dialysis further decreases the QT or the immune-based diagnostic tests to do this testing and think about offering treatment. The tailored treatment should be always depending on the patient's conditions, specific immunosuppressive regimens, and the regional TB prevalences. And also you need to be mindful about the interactions and the patient's potential DDIs or drug-to-drug interactions between the ATT and the immunosuppressive medications. And these should be monitored closely, because even if you have given them the preventive therapy, the flare-up of active TB disease is very important, because even in the transplant population, even after it's been known that if you get a TB in a transplant recipient, like a KT recipient, the mortal rate is about 33%. So you need to embed the LTBI management into the pathways of these specific immunocompromised group, like the cancer patients, the transplant patients, and the HIV patients in their programs. So in summary, LTBI is a serious threat to immunocompromised patients. The diagnosis required layered, risk-based approaches. Short course regimens are safe, effective, but you have to be individualized treatment plans. And also integrating the LTBI management is a key and important factor protecting vulnerable patients and reducing transmission. Thank you.
Thank you very much, sir, for that interesting talk. May I kindly invite the three speakers to the stage, please, in order to start the discussion. And can I also take this opportunity to invite the panelists, Dr. Anoma Siribaddana, Senior Consultant Respiratory Physician, Dr. Amitha Fernando, Senior Consultant Respiratory Physician, National Hospital, Sri Lanka, and also Dr. Harshana Bandara, Consultant in Interstitial Lung Diseases from Manchester University Hospital NHS Trust.
Thank you, Chandimani, for that introduction. My question is to Prof. Anoop. First, we initiated a dialogue on this. In the spectrum of eosinophilic airway disease, how often would you see non-asthma eosinophilic bronchitis, cough variant asthma? Then our GI colleagues often speak of eosinophilic esophagitis. Is there a link in all these conditions? And when should one suspect eosinophilic bronchitis, non-asthma, and cough variant asthma?
Thank you. That's a really practical problem where you see patients with an eosinophilic signal, but they don't have any obvious evidence of asthma. Yes, any inhalant or toxic exposure will cause a degree of eosinophilic bronchitis, so gastroesophageal reflux is one of them. Eosinophilic esophagitis itself is probably a different entity, and it's the GI manifestation, perhaps of something more systemic. But I do agree that in pulmonology, we all face a really difficult area. One of the things that helps us is the increasing technology around diagnosing airways diseases. And we realize that with access to induced sputum, you often find a significant eosinophilic component there, but also measuring the air availability is different. So I think we're all used to doing spirometry, and often in these eosinophilic bronchitis patients, the spirometry can be normal. But under challenge conditions such as methacholine, we often see some reduction in lung function. What we're now seeing also is patients with seemingly eosinophilic bronchitis who have no large airway disturbance, i.e. no changes on provocation with methacholine, but much more sensitive measures of airway functions such as oscillometry. We can see quite significant changes. So we see changes in R5, R5, R20, and AX. So we probably now saying, I would guess probably about 1 in 3 or maybe even half of patients with eosinophilic bronchitis, surprisingly, they show evidence of small airways dysfunction. So perhaps it may not be a distinct possibility. It's just that we lack the technology to diagnose airways disease more completely.
Thank you.
In eosinophilic bronchitis, how useful the FeNO be?
It's very useful because in sputum induction is largely a research-only area where we can not only require reliable sputum induction, but also the reliable assessment of sputum eosinophily. So it's an area that isn't really well accessed across many centers. So we rely on some eosinophilic signal. So peripheral eosinophil count is the easiest thing to guess, but also exhaled nitric oxide is a really, really important armamentarium for the diagnosis. So yes. Or eosinophilic bronchitis, as well as, well, I think what it tells you is that there's an eosinophilic signal in the lower, or possibly the large airways, but what it doesn't do is differentiate between the bronchitic versus the asthmatic obstructive components.
Thank you very much.
I have a question on ANCA negative EGPA, because that's a very difficult diagnosis to make, especially when the ANCAs come negative. Are there any clues in the history or anything that would point us towards the ANCA negative EGPA? And also, especially in the context, sometimes they get their Aspergillus Igs also coming as positive. And then there is that difficulty in thinking whether this is ABPA or whether this is ANCA negative EGPA.
Yeah, thank you. I think we highlighted a really difficult syndrome where patients with airways disease will show some eosinophilic signal, but don't fit the criteria for full-blown EGPA. So those who are in the middle ground, as I would say, are really difficult as well. And we've labeled them as hypereosinophilic asthma with systemic manifestation. And the clues are really excluding, being vigilant throughout the patient's journey, excluding other eosinophilic disorders. I didn't present a patient today, but we've had another one who had presented with asthma symptoms, did very well with anti-IL-5, then developed an eosinophilic signal, but without the multi-organ disease. And when we looked, we found Aspergillus in the sputum as well. So you're quite right to highlight that as an alternative cause, not only at the beginning, but being vigilant throughout as well. But the ways of differentiating it is often the degree of eosinophilia often gives you a clue, especially with sputum eosinophilia more than 50%. The idea that you have recurrent ground glass opacification on a CT scan, sometimes invisible on a chest X-ray, is another clue as well. And also, sometimes the requirement for persistent oral corticosteroids as well is often an indication of something else going on. The reason you're not able to taper them off may not just be the eosinophilic component, but maybe something else. And the two cases that are demonstrated showed quite clearly is that whilst we're very good at treating using anti-IL-5 and 4 and 13 strategies for treating eosinophilic airway disease, we don't really have a good handle on the vasculitic component as well. Oral corticosteroids do. So I think the message of my talk was having caution in those individuals where you've got a persistent signal, their asthma improves, but things are not quite right. It's just being very careful about not tapering the immunosuppressants and the steroids.
Thank you, Professor Chauhan, for the excellent talk as always. So I have one question around Kenalog. So the Kenalog is being used in some centers as a therapeutic trial before giving biologics. In Manchester, we do not use routinely, but some challenging patients. So what is your experience and what is your guidance about Kenalog before starting biologics?
Yeah, it's a really good question. I think Kenalog still has a useful role, and it has both a diagnostic and a therapeutic role as well. In individuals where you suspect they still have eosinophilic disease, but you suspect for some reason that there's no absorption of inhaled corticosteroids, with the commonest reason being that they're not taking them. Sometimes then doing a phenosuppression trial through Kenalog is often helpful as well. But Kenalog often helps in those particularly patients with allergic eosinophilic disease who are variable with treatment, but also at the beginning of the allergic season, a small dose of Kenalog at about 60 to 80 milligrams is sufficient to tide them through as well. But with the advent of biologics in the UK and Europe and Americas, that's kind of changed our practice. We don't use Kenalog as much.
Thank you very much.
Kenalog is IM triamcinolone. It's triamcinolone. Yes. On the subject of pheno, when we are doing pheno, either for monitoring and or for phenotyping a patient with asthma, often we have to withhold the inhaled steroids, and the patients can't be off their steroids. Is the pheno tracking or correlating pheno with your ACT scores more important?
I think because patients with severe asthma have multiple phenotypes, so some will be eosinophilic, some will be post-granulocytic, and others will probably neutrophilic component. And therefore, depending on the phenotype, you have to assess whether or not a disease control questionnaire is sufficient or eosinophilia. So in people with T2 high disease, if you have an excess pheno, then yes, it's a very useful tool for tracking. For patients agnostic of phenotype, certainly disease control and quality of life measures are really important, as is airflow obstruction, as is the utility of using modern technology for tracking adherence as well, because adherence is probably the single most comorbidity that's difficult to treat in airways disease.
Thank you. If there's any question from the audience, we can just one question.
Assalamu alaikum. My name is Dr. Muhammad Arshad. I am from Pakistan. My questions is a very common question, sir, not difficult. It is safe to treat LTBI during the pregnancy? It is safe treatment during the pregnancy?
Yes, sir. Yes, definitely. Even for active TB disease, treatment during pregnancy is very safe.
My second question, madam say that with more disease in the pulmonary disease is the without the treatment. How many disease without treatment?
Sorry, just to be clear, you're asking me how many patients with sarcoidosis don't
you
need
ask
treatment?
a slide, more disease is the without treatment. How many without treatment?
In general, we find that only about 20 to 30% of patients that present to our clinic required treatment for sarcoidosis. But I think it's quite difficult to generalize. So I will work through the questions that I've proposed to look for whether the disease is a threat to the organs and whether there's any end organ dysfunction and so on, rather than a percentage of patients. But in answer to your question, about 30%, I would say, don't require treatment.
Okay,
so 30% require treatment.
30% without treatment. Okay, madam, you asked the sarcoidosis after treatment, complete treatment, what is the most complications common? Sarcoidosis is the complete, what is the most side effect or complication after treatment this patient check the?
Okay, so the most devastating type of side effects I see from patients who are on unnecessary steroids, for example, is long-term high-dose steroids resulting in bone loss and osteoporosis, diabetes, and obesity. Those are the kind of side effects that I see in these patients who come to me with long-term steroids. But the other one that is really important is is devastating infection when they're on immunosuppressants, particularly those who have active fibrosis, because infection is a big driver for progression of this fibrosis. So, so really, it's the side effect of long-term steroids and in immunosuppressants, infection. Those are the key ones.
Okay, sir. LTBI, how many treatment less than 5-year children you treat in Sri Lanka, sir? Sri Lanka,
yes.
How many less than 5-year treat the LTBI? Latent tuberculosis?
Yes.
Under 5-year patient, how many treat in Sri Lanka?
5 years.
And
yes.
how many children?
Yes, we treat all of them.
All of them we treat.
Yes, Sri Lanka, all the Sri Lanka.
Yes, it has been the practice for over the decades. Universally, under 5 years of age, we exclude active TB, and after if they are diagnosed with just exposure only, we universally treat them.
No, how many patients? 100, 200, 300?
All the household contacts.
You treat?
Also, all the household contacts.
Yeah.
numbers we cannot
5,000.
say.
This is the
Though patients under 5 years, all the patients after you have excluded active disease receive treatment, because most of the our TB patients are treated in the government clinic. If there's time for just one final question from Professor Ho. Thank you for a very illustrative presentation. When you see progressive fibrosis or cavitated disease, how vigorously will you investigate for chronic pulmonary aspergillosis? Because we have seen patients with sarcoidosis who have aspergillosis and progression.
Yeah, I think where there's cavity, we always, 100% of the time, aggressively look for infection. So aspergillosis, TB, and TB.
I think, may I ask one last question, Ma'am Ho? Now, 3 months ago, I think we got the first study on the first-line treatment of sarcoidosis, methotrexate versus prednisolone, and it was a non-inferiority study. So methotrexate now is a first-line drug which can be used in the treatment of pulmonary sarcoid. Your comments on that, please?
Yeah, I think the main thing is to kind of adopt an approach where you are controlling the disease and then maintaining the control. And the control of the disease can be with prednisolone, methotrexate, mycophenolate, or azathioprine, depending on which drug meets the patient's requirement. So methotrexate is as fine as prednisolone. Is that your...
Thank you so much. Because that was the NEJM published this, saying that it is non-inferior. You can use methotrexate as first line. Right, thank you. Thank you so much.
Thank you for the speakers and the panelists for the very, very deep discussion about the disease. Also, we will conclude the symposium with this one. Thank you all again.
Thank you all. Could I now please invite our chairpersons to award the certificates and letters of appreciation to the speakers and panelists.
Prof Anoop Chauhan. Dr. Eshanth Perera. Prof Ling Pei Ho.
To give the tokens of appreciation to our panelists, Dr. Anoma Siribaddana. Dr. Amitha Fernando. And Dr. Harshana Bandara. Thank you so much.
Also, I would like to invite Dr. Ushani Varya Peruma to award the certificates and letters of appreciation to our chairpersons. Dr. S. Rishikesavan, Dr. Chandimani Undugodage,